I wrote it down for you here, so for your review.
Granulomatosis.
Granulomatosis with Polyangiitis. And I put here the new name for the eosinophilic granulomatosis. So the GP.
P. Also a Nazi?
Yes, I don't know where this guy. It's Churg. I'm sorry, Chi. I don't know if this guy was a Nazi or not. Yeah, but you know the classification in 2011, the ACR people, the American College of Rheumatology, they met, and that was one of the reasons. But the other reason is that they're trying to move away from naming diseases after someone. It's more like a descriptive. Like we know that, for instance, granulomas. You look for granulomas in the biopsy, and in polyangiitis because it's inflammation of multiple small vessels. So. And for the large vessel vasculitis that you need to know, the giant cell arteritis, which disease associations are the PMR and the temporal arteritis and the Takayasu. Okay, so this slide I want you guys to review on your own time. But like I said, the small vessel vasculitis, we have GPA, we have the MPA on your boards. Like, remind me your name again. Julia mentioned that we actually have we have a strong disease association with Hep B with this disease, and if you have a patient of Church-Strauss, they typically give you a history of asthma, and these patients also they have peripheral eosinophilia, or if they give you a biopsy, they have this eosinophilic infiltration, and they can have or they cannot have granulomas. So all of these diseases we treat with Cytoxan. Remember we talk about Cytoxan in young females and infertility and the cumulative dose. So, and then we have the other group of small vessel vasculitis. We have the cryoglobulinemic vasculitis. So there's two types, the type 1 and the type 2. The type 2 is usually associated with hepatitis C. That's another disease association that you need to know for your boards. They may give you a patient with mononeuritis multiplex. They may give you a patient with palpable purpura. Like if you see palpable purpura, they may not give you that, but if you see purpura and then it's actually raised, you think immediately about cryoglobulinemia. So always remember that. And they may give you a Henner-Schulin purpura. These patients can present with rash. They call it, how do they call it? Salmon? I forgot what they. It's just like a erythematous little raised. Rash. If they biopsy, they usually describe the patients having a leukocytoclastic vasculitis, and the patients with HSP can actually present with severe renal involvement. They usually carry a good prognosis from the renal perspective, and some researchers think that this may be associated with IgA nephropathy. It's more like a severe systemic manifestation of IgA nephropathy. These patients, you get treated with steroids. They don't get the typical Cytoxan. And patients with cryoglobulinemia, they get treated with the new drugs for the treatment of hepatitis C. They get steroids, and sometimes when they have like severe purpura, severe vasculitis lesions, we just send them for plasmapheresis, and that's also beneficial for these patients.
Purpura in HSP, it's usually below the waist.
It's below the waist, right? They call it the salmon. It's more like, and it's not as bad as if you think about like cryo is an emergency. HSP is more like, either you can see it in kids, but you can also see it in elderly, and it's more like a stronger form of IgA nephropathy. Why is it just located in the legs? I don't know. It's just like one of the characteristics of this disease. But it's like for your teaching is less severe involvement, less severe inflammation than the other type of small vessel vasculitis. So the medium vessel is the PAN. The association is the hepatitis B. The patients can have like necrosis and inflammation in a patchy distribution. They can present with like mesenteric ischemia. The diagnosis is done with biopsy of the skin or biopsy of one of the nerves if they present with like the mononeuritis multiplex. You treat it with steroids plus or minus cyclophosphamide, and if the patient has hepatitis B, they just need to get treatment for hepatitis B. Kawasaki, I don't have to worry about this. This is only in kids, but you need to worry because you're going to take your step 3 and your step 2. So it's only in kids. I think the kids present with conjunctivitis, I think. And
do an echo too.
You need to do an echo,
yeah.
and I think the kids.
Strawberry tongue.
It's strawberry tongue, and then
They have aneurysm of the coronary arteries.
right. It's very serious. Actually, if you miss that, this is one of the things you don't want to miss as a pediatrician. Kawasaki arthritis. Okay, in the large vessels, we have the giant cell. You know, like it's always people, elderly people. Like I'm 40. I'm gonna be 50. I'm gonna be at risk of giant cell arthritis. So, so if you have the case on your board like visual loss, this is an emergency. You need to admit the patients, do a biopsy, and do IV steroids. And you need to taper them until the ESR normalized. The PMR is also a disease of elderly people. The classic patient comes to you like proximal muscle groups with severe pain. They can't even walk, and invariably the ESR and the CRP are elevated, and that's why you can't diagnose polymyalgia rheumatica if you have a normal ESR CRP. And one of the things that is incredibly effective is prednisone. You give them one dose, and after one dose, the patients are actually like incredibly grateful, like thank you for helping me, and always look for that type of response if you encounter a question like this on your boards. So in the Takayasu arthritis, you can have patients with symptoms of claudication, hypertension, or vascular insufficiency, and you know, these patients, they can have like either the aorta or the branches, and they have like an inflammatory phase followed by like no pulse. If you hear like no pulse, this is like serious stuff. You want to call a vascular surgeon as soon as possible, and you want to call a rheumatologist. Okay, so this is the last slide. I just want you guys to always concentrate on your board. Read the question, you read the timelines, you read whether or not they're describing synovitis. And if they're describing synovitis, you know that you need to concentrate on the rheumatology causes and systemic diseases, pretty much. If they have tender points, they may give you a question more geared towards fibromyalgia. I didn't cover fibromyalgia here because fibromyalgia is a whole topic itself. But you guys know about the tender points on fibromyalgia. Have you guys ever seen patients with fibromyalgia, by the way? So fibromyalgia is not uncommon. It's a complex disease. We don't know what causes it, but we do know that there is a component of sleep deprivation, and there's also a component of mood disorders. Like sometimes the patients can coexist with depression, but they also have like exaggerated. They may have like a history of trauma or minor trauma precipitating the events, and there are some tender points. I don't remember how many. Like I think, out of the 18 tendon points, you need to have like 12. And if you Google the pictures, they can be anywhere from the posterior neck to the arms, to your thighs, to your, I think, the forearms, and also in the buttocks. These patients usually don't have any inflammatory markers. And in the community, you're going to see a lot of patients with fibromyalgia getting treated as if they had a primary rheumatologic disease. That's wrong. Number one, because you're misdiagnosing the patients, and number two, you're exposing the patients to the side effects from these medications. Like we learned today, they're not benign medications. On your boards, if you're confronted with a fibromyalgia patient, the last thing you want to answer is that you want to give him opiates. You do not treat fibromyalgia with opiates. So just make sure you know that, because it's a chronic problem. You guys know, by the way, you guys know what the FDA indications for opiates is? You guys know why we prescribe opiates?
No.
Severe pain.
Like which kind of pain? Acute pain. Like post-operative pain or acute pain, and palliative reasons for cancer patients. Like if you have a patient with headaches, if you give them opiates, that's wrong. Like that's very wrong. If you have a patient with fibromyalgia, if you give them opiates, that's very wrong. So when you guys go out, now there's a lot of, you guys need to sign when you get your DA license, you need to sign for a program, a state-funded program. It's called the Cures. And you will be able to track opiate use, and your opiate prescription practices are being supervised. Yeah.
My last rotation of family medicine, I saw a lot of patients with back pain, and
Mm-hmm.
they would prescribe tramadol for them.
Yeah, it's actually not kosher. You know, I know we do it.
What about, like if they have like stage 3 or 4 osteoarthritis?
I mean, we all do it. I'm not going to say I don't do it, but what I want you guys to learn is like you need to know the indications when you prescribe it, and you need to understand that there is a roof, there is a red line that you cannot cross. If you're prescribing more than 100 milligrams of morphine or equivalent morphine, there is an opiate conversion tables. If you're prescribing more than that in a 24-hour period, you can't defend that in court. Even if the patient said, like, don't worry, I've taken 100, I have taken 200 milligrams without any problems. And that's one of the problems with opiates, that you develop tolerance. So that means that you need higher and higher doses. But we know that if you cross that line, you're putting your license at risk. And I know people do it all the time.
So I know that they've, like the FDA has, like made stricter guidelines in the last couple of years. I was in the ER, and one of the physicians said, I can't prescribe you in the ER, like in an acute setting, more than 3 days.
Yes, that's what I do in the urgent care.
And is that like they cut it off and set it as like 3 or 4 days that you can't go past that and it's not indicated otherwise?
It's up to your clinical judgment. Some doctors are more liberal than others, but that doctor is not lying to the patient. We want more and more doctors prescribing no more than 3 days, or if you work in a setting where the patients cannot get a hold of, let's say your patient has a pain contract. You guys know what a pain contract is, right? So if you have a pain contract, you should never prescribe more than 3 days or more than 2 days. Or even some doctors are so stingy, they say, I'm going to prescribe for today. You go see your doctor tomorrow. So like pain seekers are very sophisticated and they know what to tell you. Like let me give you an example. How can you not treat somebody with dental pain? And do you have any objective way of knowing that this patient truly has pain or not? There's really no objective way. Like if you have a patient with a severe injury, obviously it's too obvious that you need to manage acute pain. But if somebody comes with acute pain, like dental pain, like that's why you have to have a workflow, a personal workflow that I have for my patients. When I work in the urgent care, I give them 3-day supply. I know it's enough for them because I work at Kaiser. Kaiser is very good like for access. I know that they can get to the primary doctor or whoever is covering within 3 days. It depends on the setting that you're working. If the patient cannot see a doctor in a week, you can give him a week. You cannot get faulted for doing that. But what I want you guys to know is like you're being watched. Like when you prescribe, like they know exactly how much you're prescribing, and they're actually, I don't know if you guys saw that the woman. This was actually historical. There was a woman in Riverside. No, she was in the Antelope Valley. She was notorious for giving everything to kids. Particularly, kids were coming out of state, like they were driving from Colorado, and the lady had a sliding scale. Like if you want OxyContin, this is how much I charge. If you want Norco, this is how much I charge. So she was a drug dealer with a license. And she was convicted for the deaths of 2 kids that actually they drove all the way from Colorado. That was in the news like 3-4 months ago. I don't know if you guys saw that. So they were able to catch her because of her prescription practices. Like there was a red flag and they started like looking at her, and then they realized that this woman is actually, she's a dealer. And she actually was convicted. She's in prison for 50 years. And her license was removed, and she went to jail for 50 years. And which is that woman is it's terrible for our profession. That's why you have to use your clinical judgment. You have to know when to use opiates. Opiates are only indicated, if you look at the label indication, acute pain and cancer, patients that are actually dying. We use them for everything. We use them. I even show you, like for osteoarthritis, we prescribe them. Make sure that you tell the patients that there is a limit. If you're not comfortable managing chronic pain, there is a field in medicine called pain management, pain medicine. Most health plans, if you end up working in organizations, every health plan has a pain management. As a nephrologist, I never manage pain. When somebody starts asking me for these medications, I just tell them like, just go to pain management. Why? Because I don't want to be responsible for refilling prescriptions, and more importantly, for if like feeling on somebody who's actually dealing or abusing it. And I'm not qualified to do that, and that's completely out of my scope of practice. And there's a field in medicine specifically dedicated to do that. So,
do you recommend then giving them 3 days and then saying if you find that you're going to need more, then here's a referral to a pain clinic, pain management? You
can refer them. What you can do, and you're not going to get faulted. If the patient is basically legit complaint, you can give him 30 pills. 30 pills is enough. If you're having chronic pain, maybe I missed a fracture. Maybe Maybe there was something else that I didn't, you need to follow up with your primary doctor. So if you're in the urgent care setting, giving 30 pills, there's nothing wrong with that.
Okay.
But if you know that somewhere in the chart it says that the patient is on a pain contract, you do not want to give pain medications to those patients, because you're going to get a phone call from the pain specialist. Why did you give? And part of the pain contract is that I will not seek opiates from any other providers. And they know, and they come in the middle of the night. You know another strategy that pain seekers do? Like the urgent care where I work, it closes at 10 p.m. So at 10 p.m. after a day of like seeing patients from 8 a.m. until 10 p.m., you're so fed up, dude, that you just want to get the hell out of there, right? Like this is just human nature. Like you're human and you get tired. Like you're at 10 p.m. you're so tired. They know specifically to request the last appointment of the evening, so they get a doctor that doesn't want to bother, because it's very difficult. You know, as physicians, it's very difficult for us to explain to a patient why we don't do, for instance, antibiotic for viral infections. You know how time consuming and how exhausting that is? It's very time consuming. Like even to explain to patients that we don't prescribe antibiotics for bronchitis, because this is evidence-based research. This is not something that we're coming up like changing preferences. It's very exhausting. As a doctor, like you
know where this goes.
Oh, yeah.
Jordan from his daughter wants to know if Ernest's going to be alive in 9 months.
Oh, that's ridiculous. We're gonna see him tomorrow.
Who?
Ernest? Yeah, but this isn't. She wants to talk to. She's a nurse and wants to talk to Spencer directly about.
Oh, Kernick.
Kernick?
Ernest.
How old are you again?
I think he's 82, maybe.
No, I think he's at least that. I think he might be more than that. And I mean, last time when he had that stent, it was like a nightmare trying to get him in and out and stabilized because
Well,
he's.
I've seen him before